Can you talk a little bit about the diagnostic classifications and application to kids?
The really terrible problem in the last 20 years since DSM-4, and the one I'm most embarrassed about, is the fact that the diagnosis of mental disorder in kids has absolutely skyrocketed, and the use of medication has followed from that. We made some changes in DSM that were responsible for this, but a lot of it happened outside of our control and watch. Basically, the drug companies realized that kids were the great new market. They had already saturated adults, and they saw two great new markets. One, old folks, so they went into the nursing homes like gangbusters for antipsychotics, but the other market was kids. And they advertised ADD like crazy. They advertised a diagnosis that we rejected in DSM-4, childhood bipolar disorder. We said that childhood bipolar disorder should be diagnosed according to strict criteria. But a group at Harvard, working very closely with the drug companies, elaborated the idea that if you had a temperamental kid, without meeting the classic criteria of ups and downs, just a temperamental kid, that was childhood bipolar disorder, that kids presented differently. And the rates of childhood bipolar disorder increased by 40 times. 40 times. A tremendous amount of very dangerous antipsychotic and mood-stabilizing medication given to kids. And get this, kids will gain a pound a week. You take an 11-year-old and you put him on an antipsychotic medication. On average, he'll gain a pound a week in the first 12 weeks. He'll go from 111 pounds to 122 pounds in just 3 months. We have a childhood obesity epidemic. And the idea that we're pouring these medicines into kids who basically don't have an indication for them is one of the things that most bothers me about what's happening in psychiatry. We weren't responsible for this, but we didn't stop it. And I think the third area of child excess in diagnosis is autism. So we have ADD, we have childhood bipolar, we have autism.
Right.
And here, it wasn't the drug companies. It was the school systems and the parents. That if you had the diagnosis of autism,
you get services,
you get a
supports,
lot of extra services,
resources.
And fine, except the diagnosis is often inaccurate. The studies suggest that about half the kids who are getting the diagnosis now grow out of it. If you did careful, systematic evaluations of the kids getting the diagnosis, half of them wouldn't meet criteria. I think kids deserve school services, but it shouldn't be coupled to the psychiatric diagnosis. The psychiatric diagnosis of autism is not a predictor of who needs what service.
So you're starting into an area that I think has been pretty, in some ways, controversial in diagnostic classification, and that's the inclusion or not of functionality and functional criteria. Why ought we not be looking to see how someone is functioning and treating and responding and intervening based on having sufficient dysfunction, whether there's a label that can be put on it or a diagnosis?
Just having symptoms alone does not make for a mental disorder diagnosis. You need to have the symptoms in the way that they typically present themselves. They have to be presented for a duration that means they count.
Right.
But also you have to have clinically significant distress or impairment. And if you're prescribing school services, it should be based on school impairments,
right,
not a psychiatric diagnosis.
Right. You know, you talked about ADD, and I wonder was the change in the, and you probably know the actual diagnostic classification for DSM-5 better than I, was the change to that diagnosis with kids and their emotional dysregulation, or I can't remember exactly.
Okay.
Was that an attempt to try to prevent some of what was happening with overdiagnosis of ADD?
Yeah, this is a good example of good intentions gone awry. The child psychiatrists and psychologists were concerned, rightly, that there was this great overshoot in the last 20 years, excessive diagnosis of childhood bipolar. So they wanted to introduce something to correct it. And this substitute diagnosis is essentially temper tantrums. They're hoping to tease out temper tantrums and say this is a different diagnosis than childhood bipolar disorder. And the thinking is that this is less lifelong, it doesn't imply medication treatment, that it's a great substitute defining temper tantrums as a diagnosis as opposed to childhood bipolar. There's a big problem with this. The way to attack childhood bipolar disorder is directly. There should be a huge black box in DSM-5 beware the overdiagnosis of child with bipolar
Right.
disorder. The academies in pediatrics, in child psychiatry, the American Psychiatric Association, the American Psychological Association should all be sponsoring educational endeavors, teaching practitioners we have gone way overboard. They should be pushing back against the drug companies. There hasn't been a pushback against the drug companies. This should be a professional responsibility. Adding a new diagnosis to the system is the worst possible way of fighting the drug companies in their excessive promotion of child with bipolar disorder, because it gives them a new target to promote. At this point, the drug companies can begin thinking about temper tantrums as a new target